So I would like to go ahead and introduce our first speaker for the morning. Dr. Parinda Mehta is currently an associate professor of clinical pediatrics at the University of Cincinnati College of Medicine. She currently practices in the Division of Blood and Marrow Transplantation and Immune Deficiency at Cincinnati Children's Hospital Medical Center. Originally, Dr. Mehta began her medical education in Bombay, India. She completed her pediatric residency at State University in Syracuse, New York, and later came to Cincinnati Children's for her Peds Hemonc Fellowship there. She has remained there as BMT faculty for the past 8 years. Dr. Mehta has over 30 manuscripts published in the field of hematopoietic stem cell transplantation, and she has received many national awards for her work in this field. Please welcome Dr. Mehta.
Thank you, Paula, and for that kind introduction. It had no bias that I'm from Cincinnati. She really meant it. Good morning and welcome. I am honored to give this presentation, and please feel free to interrupt, or we can have question answers at the end. I'm fine either way. So we're going to talk about hematopoietic stem cell transplantation for non-malignant disorders. And if we think about what non-malignant disorders are commonly transplanted, you come across a few common things which are seen both in adults and pediatrics, and some of them are exclusively seen in pediatrics. And I understand we have a mixed crowd here, so bear with me if I go too much pediatrics, but it does have a message for you, remember. So hemoglobinopathy, as we commonly know, that's sickle cell disease and thalassemia, which are disorders of hemoglobin, which are curable by bone marrow transplantation. Any disorder where there is hematopoiesis is inadequate, meaning, to give you an example, bone marrow failure syndromes. So this is how a normal bone marrow looks. All these blue cells are the progenitor cells that makes the blood cells. The larger one out of those are the megakaryocytes. And this is what a marrow of somebody who has a marrow failure syndrome looks like, which is empty. These white spaces are the fat cells. So you don't see any of those blue blood-making cells, so that's why they don't have the counts, and their counts fall and they need transfusions. So what causes aplastic bone marrow? In pediatrics, it's the congenital marrow failure syndromes, which can be Fanconi anemia, Shwachman-Diamond syndrome, or dyskeratosis congenita, and there are many others. For the adult NPPAs, there's a quiz, and they have to remember all these names. Just kidding. But idiopathic aplastic anemia, which is seen both in pediatrics and adults, which can lead to this type of picture, and this is something that we can fix with bone marrow transplant. Sorry, not going forward, going backward. Here. So metabolic disorders are another group of disorders which can be cured with bone marrow transplant, mainly seen in pediatric population. Here what happens is children are born missing a certain enzyme that leads to accumulation of the previous products in the pathway, and it leads to they have large heads, they have coarse faces, they have hepatosplenomegaly, as shown here, short stature, a lot of bony abnormalities, and basically when we do bone marrow transplant, post-transplant, you can hardly say that this person had Hurler syndrome. All right. So the other disorders which are cured by bone marrow transplant are immune deficiencies, both qualitative and quantitative immune deficiencies. To give you some examples, severe combined immune deficiency, Wiskott-Aldrich syndrome, and hemophagocytic lymphohistiocytosis. Now, these are more commonly seen in pediatrics, but HLH, we have come to recognize more and more that even adult patients present with this, and we've learned how to recognize this disorder, and we now know that it can be treated with bone marrow transplant. Interesting thing about immune deficiency is that bone marrow transplant actually began with immune deficiency. In 1968, the first of the 3 successful transplants were performed, and this is one of the patients, and his name is David, and this is his sister who actually was his donor. And why this 3 transplants worked and 200 prior transplants didn't work is because by then we had slowly come to recognize the importance of tissue typing and HLA matching. And the clinicians had figured out that although David's sister was not a complete match, she was a reasonable match, and he achieved long-term engraftment and survived for a long time. So in each of these disorders, what we are trying to do with bone marrow transplant, what bone marrow transplant is doing is donor-derived cells have the ability to correct the underlying defects, either one, by direct repopulation of the hematopoietic system, so in sickle cell disease or thalassemia, you're completely replacing the blood system, or by completely replacing the immune system, like in immune deficiencies, or by indirect delivery of the missing enzymes. For example, the pictures I showed you of the kid with Hurler syndrome and some of the leukodystrophies are commonly cured with transplant. So if you look at transplant outcomes, these are National Marrow Donor Program data showing that over the last few years, or 20 years or so, we have consistently improved the transplant outcomes for non-malignant disorders. And we've done that by improvement in better supportive care, improved HLA matching of the unrelated donors, improved understanding of the basic etiology and pathophysiology of these disorders, and understanding of what are the gaps in our transplant strategies going forward and improving on each of them. So what about how have we improved the supportive care? Now, this is something that we all are aware of. We've tried to use more and more standardized therapies, improvement in transfusional support, improved antifungal and antibacterial prophylaxis, very rigorous screening for viral screening of different viruses, especially CMV, which can cause a lot of mortality in transplant setting, both in adults and pediatrics, as we know. So here is what we are showing, the effect of CMV, that over time we've actually improved survival of patients based on how we match the donor and the recipient for the CMV status before transplants. You guys have seen us talking about whether CMV is positive or not, and then picking the donor accordingly what the patient's status is. And this is important because it does affect the outcome. So what about improved HLA matching of the unrelated donors? We all know that our first choice of donor selection is matched sibling donor transplant. And if somebody doesn't have a matched sibling donor, which is 75% of our patients, you move on to the matched unrelated donor transplant. Or in the same scenario, you can use a 5 out of 6 parent donor. And if that doesn't work, then move on to mismatch-related, unrelated, or cord blood transplants. What this is showing is actually what registry data, what CIBM Chart and MDP does is over time, they retrospectively go back and type the donors' samples using the current typing techniques. So what it's showing is, so if you look at 1987 to 1995 era, if we used today's technology of tissue typing, you see that only 21% of the donors were actually well matched, compared to, say, in 2003 to 6 was 52%. So we've really improved our ability to do the HLA matching and try and come up with much better techniques to do that and improve outcome, as shown here. It is very important. It does improve the outcome if you have an 8 out of 8 matched donor versus you have a 6 out of 8 matched donor. As shown here, this was significant statistically also. So overall, this is about non-malignant disorders. If you talk about aplastic anemia, which is again seen a very common pediatric and adult transplant indication, it shows the same thing. The data shows that HLA-matched donors, patients actually do better versus those who receive a HLA mismatch graft. So how do we improve better HLA matching? Also, better transplant strategies, better preparative regimens. So these patients, how do we bring them up here? Again, we do different studies over time. We learn how to improve our preparative regimens. And Dick et al. Actually showed in one of their studies that reducing the radiation dose to 200 centigrade of TBI and then continuing the cyclophosphamide and ATG, which is sort of considered a standard aplastic anemia regimen, improved the outcomes. Also, they showed that lowering of the TBI dose did not lead to graft failure, which was one of their concerns. So this is what is shown here, where, by decreasing the radiation to 200 centigrade, you improve outcome and bring the curve up. What about unrelated? This was in a matched sibling setting. So we improved in matched sibling setting. So then you move on and see whether we can improve outcome in unrelated donor setting. And again, we were lucky and we were persistent and we did well. So this shows unrelated donor transplant for severe aplastic anemia, where we realized that addition of fludarabine, which is a highly immunosuppressive agent, will be able to we'll be able to prevent graft rejections, which is one of the common issues with transplanting severe aplastic anemia patients, and we actually did achieve that. So if you think about what have we learned by understanding the etiology and basic pathophysiology of the diseases and use that to improve our outcomes. So I want to give you a patient. This is a true story. This is one of our real patients. So a previously healthy 18-year-old male presented with severe nosebleed lasting for 3 hours. He went to the emergency room. They called the ENT. They packed his nose. Everything was fine. He recovered. No further issues. He went home. So 3 months later, he went on for a routine physical and blood work because he said he was thinking of joining the Army. And his CBC showed white count of 3,000, ANC 300, hemoglobin 5.9, platelet count of 11,000, MCV of 99. So, the physicians there did all the appropriate things that you and I will think about doing it. You want to rule out malignancy first. So they did LDH, uric acid, all those things were normal. Is there a viral infection that is suppressing the counts? All the viral PCRs were negative, hepatitis panel, HIV, he's a 18-year-old, negative, B12, PNH screen, everything came back negative. So they went ahead and made sure that they did a bone marrow, and bone marrow showed this. This is normal bone marrow showing different normal hematopoietic cells, and this is this patient's bone marrow. As you can see, it shows blasts. So the flow showed approximately 3% blast, and I know this is non-malignant talk, so I am getting there. And the fish showed monosomy 7 and 5 deletion 5p. Cytogenetics confirmed these findings, and he was referred to Cincinnati Children's for bone marrow transplant with the diagnosis of myelodysplastic syndrome. Very straightforward, 18-year-old, previously healthy, bone marrow shows cytogenetics confirmed. This is MDS. This could have gone to University of Cincinnati. It showed up at Children's. And, normal transplant preparative regimen would have been, standard dose busulfan Cytoxan. But what's missing here? What's missing is history. So when the further history was taken, he had a history of a preauricular tag at birth that was surgically excised, and he also had 2 thumbs on his right hand that again was repaired at 2 years of age. So I don't expect the adult people, but pediatrics, people should know. Michelle Harris. What will you do next? Very nice. So yes, we did a DEB test, diepoxybutane test, which revealed increased chromosomal breaks, as shown here. This is FA control, some patient who has FA, and if you look at our patient, his chromosomes are broken, just like this one. So basically, it confirmed the diagnosis of Fanconi anemia. So the final diagnosis was Fanconi anemia with myelodysplastic syndrome. So Fanconi anemia is one of the congenital marrow failure syndromes. Congenital marrow failure syndromes have a couple of things in common. They all have some congenital abnormalities. For example, a lot of them are short. They have some cafe au lait spot skin abnormalities. And specifically, Fanconi anemia patients have thumb or radial abnormalities. They have missing thumbs, double thumbs, abnormal radius, missing forearms, things like that. Or they may not have any congenital abnormalities, like our 18-year-old, 6 foot, 120 pounds, or whatever his weight was. He had nothing that we could see. But the common other feature is over time they develop progressive marrow failure, and they are at higher risk of developing myelodysplastic syndrome and leukemia. So this is something I want even the adult people to remember, to think about it. When you have a young patient with myelodysplastic syndrome, please think about underlying marrow failure syndromes. You always want to do a DEB test, rule out Fanconi anemia, and send telomeres to rule out dyskeratosis congenita before you transplant these patients with full preparative regimens, and I will tell you in a minute why. So we know that transplant is curative for many of these disorders, but it is very challenging because these patients, what they have is inherent chemosensitivity and radiation sensitivity. They do not tolerate the normal doses of chemotherapy and radiation. Their cells are fragile. They will crash and burn on our BMT unit if they receive full prep. So how to overcome these challenges is the best example of that comes from our experience in transplanting patients with Fanconi anemia. This is Dr. Fanconi who first described this disorder, and that's one of his first patients. So transplant for Fanconi anemia started in Paris in 1970s and 80s. So how does it start? How does somebody just decide that how are you going to transplant these patients? So based on prior experience. So what experience they had was patients with leukemia, how to transplant patients with severe aplastic anemia. And based on that experience, what they did is they used 250 milligrams per kilograms of cyclophosphamide for 4 days, total of 200 milligrams of cyclophosphamide as a preparative regimen for these patients. Okay? What did we see? Very high morbidity and mortality. 4 out of 5 patients died, which is, you would think, oh, that's horrible, that's bad. Yes, it is. But this was actually one of the best things that happened, and we learned that it's the first clinical evidence that special sensitivity is there for these Fanconi patients to alkylating chemotherapy agents. So the Paris group then is the same group that further confirmed that these cells are also sensitive to radiation. And they developed in next 3 years, you look at this, 1983, they developed a new standard regimens, which is reduced doses to transplant these patients. Low-dose cyclophosphamide and with 5 gray of thoracoabdominal radiation, which became the standard regimen for next few years. So how did we improve further? So this is what happened. Patients with Fanconi anemia, they saw that using the reduced doses of DNA damaging agents, what they saw is they have very high rate of rejection, and they also developed quite a bit of graft versus host disease. So they said, so first intervention was addition of APG, which really improved the graft versus host disease. Then came along the fludarabine. Fludarabine is highly immunosuppressive agent, and addition of fludarabine to this regimen actually has changed the scenario for transplantation for Fanconi anemia. It significantly improved the rejection rates, and matched sibling donors started to do much better and better. So then next we said, okay, fine, we've taken care of the rejection, we've taken care of the GVHD, so what else can we do? Well, long-term side effects. These are the patients who have inherent predisposition to development of leukemia, development of solid tumors over time, and we're giving radiation to them. So can we get by without radiation? And then people tried matched sibling donor transplants without radiation, and with the use of fludarabine, it worked. Over time, we improved outcomes of unrelated donor transplant also, almost up to 75 to 80% survival. So that's very good. I mean, what else can we do next? Well, the question was, can we do unrelated donor transplant without radiation? And although I told you all this in like 3 minutes, if you look, really, it took 20 years to get here, and a lot of patients were lost on the way. So we've learned a lot over the last 20 years. And then the question about unrelated donor with TBI came, which everybody was very worried about, scared that, well, it may not work. These patients reject, and if you don't give TBI, they may not work. But we are pleased to see that more and more reports are coming out now that we can transplant Fanconi patients with unrelated donor without using radiation. So the report from Brazil uses Cytoxan fludarabine in ATG, and in the United States we have a multi-institutional study that uses PK-adjusted busulfan, Cytoxan, fludarabine, and ATG. And now we can do unrelated donor transplant without TBI. So this is how we have progressively made improvement in our outcomes from understanding of the basic etiology and pathophysiology of the disease. These are not these transplant protocols that we see on our floors. Our patients get chemo. We use it every day. They just don't come up. They just don't show up overnight. People have worked very hard. People before us have worked very hard for us to see such good outcomes. So, what can we do by understanding the gaps in our previous transplant strategies for this disorder? To give you an example, thalassemia, transplant for thalassemia patients, before transplant, these patients are usually classified based on how much chelation, regular chelation they've received, whether they have hepatomegaly or not, and on their liver biopsy, they have fibrosis or not. So patients are classified as class 1, 2, and 3. And, class 1 are the best patients. They've had regular chelation, no hepatomegaly, no fibrosis. And class 3 are the ones which have not had the regular chelation. They have massive hepatomegaly. They can have fibrosis on the biopsy. And why this is important is because it affects the outcome. So if you look at class 1 and 2 patients, they do really okay, quite well. But compared to that, class 3 patients, survival was much lower. So these initial experiences definitely told us that there's something that needs to be done for these class 3 patients. They're not going to improve by just using standard BuSci, which is a common transplant matched sibling donor regimen for thalassemia. So again, people used their imagination and backed by the medical science evidence, and we did improve the outcomes of class 3 patients by using, pre-transplant hydroxyurea, azathioprine, and by addition of fludarabine. So this is in the matched sibling donor transplant patients. One of the things that we realized when the transplantation for thalassemia was happening is that unlike the patients with malignancies like leukemia and lymphoma, where residual host cells are predictive of relapse, meaning if you have mixed chimerism, if your patient with leukemia has less than 100% chimerism, you're worried that that's it, his disease is coming back. However, patients with thalassemia, we saw that they could live with mixed chimerism and not need transfusion and have a long life. So this told us that, hey, so that means we can use reduced intensity transplants. What it will do is, yes, so that will give us mixed chimerism, but that's okay for non-malignant disorders compared to malignancy. And it will decrease the treatment-related mortality. And that's how we started to use reduced intensity transplants for non-malignant disorder. To give you an example, this is data from our own center. We are a large HLH referral center where we used to use standard BuSci ATG for unrelated donor transplant for patients with HLH. And the outcomes were not great, but they were better than patients dying, so, 50%. But then we moved on to reduced intensity transplant, and this is where we saw the improvement. So this has been the progress that we've been able to make by using reduced intensity transplant. And similarly, we started using the reduced intensity conditioning, and commonly used at our center is the campatfludarabine melphalan, which many of you are familiar with, in even marrow failure syndromes other than Fanconi anemia patients. So patients with Shwachman-Diamond, patients with disc keratosis, even patients with idiopathic aplastic anemia. And we showed significant improvement in their outcome. These data were presented on Wednesday as a poster and is available in the abstract book. And so I think we've come a long way, as you saw, by understanding these gaps that we had learned from prior experiences. And looking forward to future, we can continue to improve our understanding of the etiology, basic pathophysiology. Every day, new genes are being recognized for some of these congenital marrow failure syndromes or other disorders, and we are learning more and more about them. We can optimize the utilization of reduced intensity transplants, maximize on the goal of stable mixed chimerism, and develop newer strategies for further reduction of graft failure and GVHD. Thank you for your attention, and I'll take questions. This last slide usually is for oncologists. I tell them BMT is the best.